Thank you very much for a kind introduction. I'm Taku Sugawara from Japan, and I'm very honored to be here to give a talk to you at the ISMIL online neurosurgery meeting. So I'm talking about the sacral perineural cyst and talk about the novel wrapping surgery. And let me introduce. I'm a hospital in Akita Prefecture, in Akita City. It's like 600 to 700 kilometers north from Tokyo. So, okay, today's content is the one literature review of sacral perineural cysts, and the second wrapping surgery of the radicular symptoms, and the third wrapping surgery for Kanada'daki syndrome. The third, I talk about the three topics. And I'm starting with the first one. So there's basic things like the sacral perineural cyst. It's also called Tarlov cysts, or dilatations of the root sleeves, commonly found in the sacrum. The prevalence is 1.5 to 9%, the most common at S2 level, so commonly in female than in male. And the majority of the cysts are asymptomatic and found incidentally on routine spine imaging. This is an image from the Wikipedia, so you see those cysts in the sacrum here. And first, this is called Tarlov cyst, and first described by Tarlov in 1938. This is the images from his paper published in 1970. This is the myelogram of the woman aged 46 complaining of sacral, coccygeal, and buttocks pain for 9 months. So you see the normal myelogram here. But 3 months later, she came back to the hospital, and plain X-ray showed this dilatation of the nerve sleeve here. There's several cysts because oil-based positive contrast media is not removed from the body after injection. He also noted that the erosion of sacrum here, erosion of sacral body here in this picture. So they all reported in a paper in 1970. And this is a diagram by Tarlov, Dr. Tarlov, and the perineural cyst lies at the level of dorsal root ganglia here. And the cyst wall contains neural elements. Space within cyst may have potential communication with the subarachnoid space, allowing for delayed but not immediate filling of myelographic filling here. So this is a perineurin, not dulamin or epineurin. This is perineurin, it is dilatation of perineurin. This is the definition of Tarlov cyst. So he also had this figure that they're showing the gross specimens. He removed those S2 perineural cysts and find histology that the alert particle in the center of the cyst, perineural part of the cyst, usually connected within an with intraneural spacing. And in the panel B, you see multi-loculated intraneural cysts of the neural part of the cyst. In the panel C, the generation of tissue with a cyst formation in region of the serial root ganglia in this paper. And these cysts are frequently multi-loculated. Therefore, complete removal of the cyst along with the root from which arises preferable simply to unlock the cyst, though the latter procedure may be necessary in cases with multiple cysts. So there are a lot of images on the online. We can see it. So this photo is showing that the myelogram, but the delayed filling, it's not filled, the CT myelogram at the early stage, and there's a bone erosion. Yeah. And this paper, the adjacent nerve root compression, like here, the S2 root is compressed by the cyst. So it's already, its findings already reported in the paper in 2011. So the treatment of the symptomatic SBC in past literature, that I showed this slide, and symptomatic SBCs that induce intractable low back pain, radicular symptoms, or bladder bowel dysfunction require surgery. SBCs communicate with the spinal subarachnoid space and increase in size through ball valve mechanism, the one-way valve mechanism, leading to compression of the nerve roots in the cyst or the adjacent nerve roots or irritation of the periosteum. And the cause of the symptoms was unclear, and therefore the treatment strategies was controversial. And surgery for SBC in past literature includes the percutaneous image-guided cyst aspiration with fibrillin glue injection and CSF shunting operation from the cyst to the to the subarachnoid space or anywhere. And decompressive laminectomy has been also done. And 2000 or later, there's a lot of cyst manipulation procedures in the literature. They did the penetration, imbrication, or neck ligation, and those procedures are often associated with low effective and high complication rate. So these procedure causes CSF leak or septic meningitis or nerve injury, etc. This is a penetration in imbrication. It's commonly done in the literature. There is a cyst SBC, and we open the cyst. It's called a penetration, and then overlap those edges to reduce the cyst in size and try to prevent the CSF leak from here. And another way is the neck ligation. In some paper, they ligate the neck simply at the proximal part of the cyst or the lateral part of the cyst. But there are some problems doing those procedures. The risk of CSF leak, root injury, or re-expansion. Even if you do imbrication, there's a risk of re-expansion and compressing the nerve roots by the SBC wall of the SBC. And it's a literature review from 2000 to 2019. And they describe the treatment procedure, the penetration, the imbrication, and neck ligation, or defect repair, or cyst wall clipping. There are a lot of different procedures. But there are a substantial number of complications, like CSF leak or nerve root injury or infections. And long-term success rate is not really high. It's, in some papers, it's 50%, but in the success rate is 50 to 100%, mostly on average of 70 to 80%. And some papers did not do long-term follow-up. So to summarize the literature, SBCs may induce intractable low back pain or radicular symptoms and bladder or dysfunction. And the cause of the symptoms is unclear, so no standard surgery exists right now. So we move to the second topic. It's wrapping surgery, invented by ourselves for radicular symptoms. We showed a study here. So we published a paper entitled Novel Wrapping Surgery for Symptomatic SBCs. And in this study, it's examining that is this method effective to treat radicular symptoms. This is a mechanism to develop radicular symptoms. This is our hypothesis. If there's a ball valve or one-way valve structure at the neck of the cyst, there is no increase in size of the cyst, but then the cyst does not compress the adjacent roots or adjacent structures. But if there is a ball valve mechanism of the neck of the cyst can get larger, and they compress the nerve roots or adjacent structures of bone or nerve roots or cover the aquarium. So the symptoms are caused by the impingement of the adjacent nerve root between SBC and sacral wall. So these are our hypothesis to develop radicular symptoms. And this is our new surgery. The schematic drawings I'm showing here is if there is a left S3 cyst here, and if there is a compression of the S2 nerve root laterally from the cyst. So we first do laminectomy or laminotomy and expose the cyst and nerve roots. And first we puncture the cyst and remove some fluid. It's CSF. We remove some CSF to make it shrink. So, and we dissect the nerve roots, surrounding nerve roots from the cyst, and put some artificial membrane, artificial non-expandable membrane. And the membrane is then adjusted to an adequate size. It's closed with titanium non-penetrating clips. This is our new wrapping procedure. So to evaluate this procedure, we selected the patient with SBCs who had only a radicular pain-like symptom with an obvious root compression identified on MRI findings. So there are 4 patient selection criteria. Number 1, patients presented with severe leg pain resembling sciatica, occurring in the buttock to the posterior or medial part of the surface of the one leg. And number 2, MRI demonstrating a large SBC, diameter is 15 millimeters or more, that compressed a single or adjacent root on the same side. And number 3, the pain was exacerbated by positional change, such as standing position, coughing, and the Valsalva maneuver. And number 4, the pain was not improved after non-surgical treatments, such as medication, injections, or physiotherapy for at least 6 months. These are the criteria. And the imaging studies performed like follows. The preoperative diagnosis of SBCs was based on the MRI findings, T2 and T1 images, sagittal axial images, and MR myelographic images were carefully examined to determine the nature of the cyst and the completion of the adjacent structures on 1.5 or 3 Tesla MR images. And postoperatively, MRI was performed within 1 week after the surgery, and then 1 year after the surgery. The increase in size of the treated cyst at 1 year after surgery compared to the size at 1 week after surgery is defined as regrowth. And to evaluate the patient's symptoms, we use the numeric rating scale, NRS 0 to 10, to evaluate the severity of the pain. And the pain score was recorded preoperatively 1 week after surgery and 1 year after surgery. In addition, the NRS score was obtained at the final follow-up in a face-to-face or a telephonic interview. Now, an increase in NRS score after 1 year or at final follow-up is defined as recurrence. And these are first 7 cases we reported in the Journal of Neurosurgery to 2017. It's pretty old cases. And they all have leg pain on one side, age between 32 to 66 years old, and 2 females and 5 males. And the treated cyst is anywhere between 15 millimeters to 41 millimeters. And I showed you the case 3. She's 32 years old. The 1 year ago, she noticed the pain from the side of her left thigh to the area around her anus, which did not improve with NSAIDs and pregabalin. The pain worsened when standing and walking and improved when lying down, but gradually the pain became more intense even the lying position, causing sleep disturbance. Her pain score was 8 and have epithesia. Sorry. And MRI showed SBC at the S2 level. And there's a root compression of S2 root here on the left side. And the CT showed a minor bone erosion at the posterior surface of the SBC. The cyst size is 2.5 by 2 by 1.5 centimeters. This is the surgery of this patient. First, we remove those S2 lamina. Try not to disrupt the wall of the cyst. And then puncture the cyst with a small needle and remove some CSF from the cyst. So reduce the size of the cyst, and then dissect the adjacent nerve roots from the cyst. And this is a S4 roots, and laterally we saw that the S2 roots. After dissection, we put there's artificial membrane, non-expandable membrane, we actually use a Gore-Tex membrane for this purpose and close the membrane with titanium plates at the adequate size. We see the postoperative ML images. So S2 root was compressed before surgery by the cyst, but compression is resolved after surgery. And her pain disappeared from NRS 8 to 0. Sensory disturbance and sleep disturbance were improved, and she was very happy after the surgery. And show you the next patient that did the case 5, the 36-year-old male. He had an intractable pain in the right leg for 8 months, and he received conservative therapy at the pain clinic for 6 months, although the severity of the pain was not relieved. When he was referred to a hospital, his NRS pain score was 9. So pain is here from the buttock to the posterior surface of the thigh. The pain was worsened on the positional change, such as standing, walking, and coughing. The preoperative MRI showed multiple cysts, but the S3 cyst is the largest one, and there's a bony erosion here, and there's a S2 root compression on the right side here. And we did the same surgery at the patients before, and post-operatively, we see that the compression has been disappeared here at the right side, and the pain was disappeared also. NRS 9 was changed from 9 to 0 after surgery. So the outcomes of the first 7 patients shown in this table. The 5 out of 7 patients gained complete pain relief. But in 2 patients, substantial pain relief, like in the case 2, NLS is improved from 7 to 2, and then patient number 6, substantial leg pain relief, but unchanged buttock pain. So this patient was later diagnosed as right superior gluteal nerve enteropathy. That's why the buttock pain is not improved. So made some discussion in the paper. This method has advantages compared to the previously reported microsurgical procedures, such as cyst resection, fenestration, and imbrication. This novel technique is simple and easy to perform, and wrapping the SBCs with the non-expandable membrane permanently prevents regrowth. And post-operative CSF leakage does not occur because only a puncture with a small needle is required. These are the advantages. And we just place our present study at the bottom of the table. So we had 100% initial improvement rate and no recurrence after 39 to 90 months follow-up. So, and no complications. But there's a different discussion here. The symptoms of SBCs include lumbago, sacral pain, radicular pain, motor weakness, bowel bladder dysfunction, tinnitus, also status and headache, and they're exacerbated by postural changes such as standing, walking, coughing, or Valsalva maneuvers. And those wide variety of symptoms in patients with SBCs makes the comparison between pre and post-operative status very difficult. And so only the patients with radicular pain-like symptoms were selected in this study, and to simplify the comparison, the patients with other symptoms were excluded from this study. That's why we only did 7 patients in this paper. So to summarize the topic 2, the wrapping surgery for radicular symptoms, the pain was dramatically improved in all patients. Afterwards, after this study, we did 12 more patients all over Japan, and 90% all patients were improved, and there are no complications so far, and no recurrence after a long time follow-up. So this procedure is that's good to know, I guess. So move to the third topic, the wrapping surgery for Kanada'daki syndrome. So we are doing this study right now. There we show the recent case. She's a 45-year-old female. She had a 2-year history of pain and numbness in lower half of the body, and numbness in buttocks and the thighs and back of the lower legs, and the perineural bowel around the anus. She had numbness of the and she had a strong pain at this area around the anus, and pain score was 9. And she also noticed urinary and fecal incontinence since 6 months ago. And actually, she was a nurse working at the other hospital, but she had a very hard time to work at the hospital. So preoperative MRI showed that the SBC at the S2 level in compressing the bilateral S2 roots here, and mild myeloma is showing that there's a right S2 cyst, S3 cyst here, and this is a left S4 cyst, and there's a compression of the S2 bilateral S2 roots here, and maybe it's not very seen on the MRI, but maybe the cyst may compress those left S3 and 5 roots. And we decided to perform surgery, and this is a preoperative planning. So we did MRI and CT fusion. In this case was the surgery was performed 4 or 5 months ago. So the way we are doing surgery right now is pretty much the same as in these patients. So we do MRI, CT fusion, and decide the laminotomy on the sacrum here, and we usually do osteoplastic laminotomy to wrap the cyst, and in this case to wrap the 2 cysts with non-expandable membrane. So like 6 centimeter incision was planned. And for every patient, we are now taking the videotape before the day before surgery to make sure that the patient symptoms in the hospital. Yeah, so we skip everything in Japanese. I skip some video. And this is surgery. This is S1-2 level and S3-4 level. First, I made a midline incision on the sacrum and exposed the sacrum, the spinous process for sacrum, and export the laminar from S1 to F3 and measure those, the size of the laminotomy. And we often use those surgical saw to make a step-plastic laminotomy. So upper laminotomy is and the lower laminotomy is made by surgical saw, and in laterally we use diamond bar to cut those lamina. So after laminotomy, the sacrum is taken out. So not to disrupt those wall of the cyst. So we gradually lift up the sacrum and take it out. So this is a L4, S4 cyst, and this is S3 cyst. So we are making the dissection from the adjacent nerve roots or adjacent tissues. It's sometimes difficult in some part, and sometimes not. So from the S4 cyst laterally, we see that the F3 nerve roots here, there was a strong adhesion of S3 root onto the S4 cyst. So it took some time to dissect those nerve roots. And at some parts, so when we find the right plane to dissect, it's easy to dissect the cyst from adjacent tissues. This is S4 cyst, which you see some epidural fat here. And this is L4 nerve root, right S4 nerve root. This is the S4 cyst on the left side. This is the S3 cyst. So continue the dissection of the S3 root. So actually we did the puncture. We don't do puncture of the cyst anymore because there is a ball valve, a one-way valve structure here. So we push, after we push the S4 cyst in this case, so we can reduce the size of the cyst. And in the meantime, before the CSF comes back to the cyst, we can dissect the cyst from the nerve roots. So finally, formally stick the S3 root towards dissect from the S4 cyst. And you see the epidural venous plexus is here. So we have to take care not to injure them or stop bleeding. We need bleed. After dissection, we put the Gore-Tex membrane, or it can be other membranes, other non-absorbable, non-expandable membrane. We use the Gore-Tex membrane, and then wrap the S4 cyst first, and cut the membrane at the adequate size. And place the titanium clip. It's very easy to do. You can suture it, but the clips are easier. And there is you see here there's a So injury on S2 root here, there's a bruise on the S2 root by the compression by the F3 cyst here. So can often see the injured nerve roots in the surgery, the S4 roots. And S2, 3, 4 on the right side, and S4, the S3 and S2 roots on the left side. All roots are from S2 to S3, S4 are exposed. And afterwards, we place the laminar back onto the sacrum and use the suture to fix the sacrum. Okay, so what we are doing right now for the S-basis surgery and wrapping surgery is like this. And this patient had very good improvement in symptoms afterwards. And you see that the S2 roots became visible, round, and visible on the postoperative MRI. And you see on the myelogram, it's the cysts are disappeared, substantially disappeared. And we did interview again, and 1 week after surgery. And again, everything in Japanese, so we just made those slides. The pain was improved from 9 to 1. She just had one pain on the sacrum after 1 week after surgery. And numbness was completely resolved on the day after the surgery. And urinary and fecal incontinence was completely recovered after surgery. So to summarize those topic 3, the pain, numbness, and bladder bowel dysfunction were improved in all patients. Total of 4 patients so far to date, and there are no complications. But we just started this surgery for wrapping surgery for Kawada equina syndrome. But the long-term follow-up is needed to draw conclusions. So it came to the final slides. There are some take-home messages for me. SBCs may cause pain and numbness on the posterior surface of the leg and urinary or fecal incontinence. And diagnosis and patient selection for the surgery is very, very important. The wrapping surgery is simple and safe and effective, and I recommend this procedure. Thank you very much for
thank you, Professor. It was a great lecture, an informative lecture, and I liked it very much. Thank you.
thank you.
First of all, I want to ask a question. When you choose the patient, do you run any other test than MRI, like electromyography or something else?
Not really. We used to do like myogram, the conventional myogram, and other like myo CT, but now we are not doing that. It's at MRI. I think MRI is enough, and we don't do those electrophysiological stuff. But we do the monitoring during surgery to
That was
to
my second question. Do you use neuromonitor during surgery? So you use?
Yes. Yes, we use SCP and MAP, or Yeah, we usually do monitoring in all patients, yes.
Okay, so you recognize film terminale and EMG during surgery?
Yes.
Dear Professor, can you stop your screen sharing so we can
Yes.
see each other bigger? Thank you.
There is a question in chat part from Elena from Bulgaria, I think, about the risks like CSF leak. What do you do if you can't find the leak during this operation, or if there is leak you have done and repaired during the operation, but the patient still have headaches and complaining of it? It is not related to topic, but do you want to answer the question?
Yes. Like a wrapping surgery I showed today is like if there is a much larger cyst, there is a defect of a cyst wall. In that case, we have to suture. We have to imbricate the cyst first, and then do the same thing. But we use the question is you can find the leak during operation. If there's a leak, you have done the repair. Yeah, we do. We have to do some repair of the cyst in the cases that sometimes that the cyst is very large. The cyst wall is almost the same thing at the sacral wall. So after we do the laminectomy, the sacrum, we see that the CSF leakage. In that case, we imbricate the cyst wall to prevent those CSF leak, like in the the literature showing.
Thank you, sir. The other question is from Hasan Kamil Sucu. Thank you for your informative and interesting lecture. Most of the time, there have been large, huge Tarlov cysts thinning the sacral corpus. Anterior wall of these cysts is impossible for them to separate from the bone. When we try to separate it from the bone, easily tears into pieces like tool. Can you separate anterior wall of such huge cysts from the bone and wrap them?
Yeah, we have several cases that we have to not in this series, but before we had several huge cysts in the past, and there was there's in some case we can't see the anterior wall or posterior wall of the cyst. In that case, we have to repair extensively, but sometimes we can't suture the whole of cyst. In that case, we just use the fibrin glue or absorbable membrane to prevent the CSF leak, but not in this series. But we had that experience before.
Thank you, sir. Dr. Alper says thank you for your presentation from a neurosurgeon from Izmir. Dr. Baran Kocaman, a resident in our clinic. I want to ask a question with share screen if it's possible. He asks.
Yep.
Okay.
You can share your screen, Baran. You can turn on your microphone at the same time.
I can share my screen. There is systemical problem. No, yes. Can you see my screen?
Yes.
Yes, yes, we see.
Yes.
Thank you, Professor, for this information presentation. First of all, I learned a lot of things about perineural cysts. Thank you again. This is a patient in our clinic,
Oh, yes.
16 years old female. He came us with urinary urgency, bilateral buttock and leg pain, radicular symptoms. This is the MRI of her patient. MRI report is bilateral foraminal stenosis of multi-segment anterior cysts and 44 to 18 millimeters perineural cyst. Do you suggest surgery of the patient Tarlov cyst or another surgery for neurodegenerative disease? I want to ask this question.
I see. So, you performed surgery already, or you're considering the surgery of this patient?
I don't understand, sorry.
Are you? Did you
No.
do surgery or
No.
Okay. So what are the symptoms again?
Bilateral buttock pain, bilateral
Yes.
radicular pain, low back pain, and urinary urgency.
Okay. So we see the compression of the nerve roots around the cyst, and there are some bone erosion. Erosion.
I have a video on this MRI. If you want to show, see, I want to show you.
Yeah, but it's a difficult case. You can do the surgery, the wrapping surgery, but so there's a during surgery you see that the disrupt the cyst, and you have to do the suture, and maybe to take the anterior wall is defective, maybe. So, so I think it's possible to decompress nerve roots, but the problem is the CSF leak after surgery.
So you agree that this patient require the surgical treatment?
Yes, but the surgery is difficult in the
Yeah.
patient.
But eventually she needs, I think.
Mhm.
We cannot escape from the surgery.
I guess so.
Yeah. Thank you so much.
Thank you, Professor.
Okay.
Thank you, Professor.
Baran, can you stop your screen sharing, please?
Sure.
Professor Suju, Dr. Professor Kemal Yücesoy, raise hand.
Nurullah, if you want, quickly finish the questions and then Kemal take the microphone completely.
Luis Javier Lopez Ulloa says, what position do you place your patients in?
Position during surgery?
Yeah.
Yeah, I think so.
It's a regular prone position. It's not really so usually we don't see the CSF leak. We don't have to put the sacrum at the top of the body. Usually, no. But if there is the great risk of the CSF leak, the sacrum has to be on the top of the body, on the prone position, I guess.
Yes, thank you, sir. Fatih Erdi asks, do you rule out anyone other pathology like as canal stenosis or disc herniation?
Oh, yeah, it's necessary to for differential diagnosis. We have to do it, but in this series, There are a lot of patients with canal stenosis and associated with SPCs. So we removed those patients from the study. But of course, we have to diagnose those lumbar spinal canal stenosis or hernia at the same time, I guess.
Yes, thank you. Edwin Vasfi, a neurosurgeon from Bulgaria, says, thank you for this great lecture and introduction to us, this innovative technique. Definitely, it was eye-opening concept for me. I would like to ask, can we use muscle or artificial dura to wrap the cysts?
Yeah, little question.
Yes.
We usually use artificial membrane, Gore-Tex membrane, and I heard that the Gore-Tex membrane is not available in the United States or some other countries. Do you, in Turkey, can you use Gore-Tex membrane for the neurosurgery?
It was, but I'm not sure for now.
Okay.
There was.
So nowadays it's found, the Gore-Tex membrane was found to cause the adhesion of the surrounding tissue. And I think that in more and more countries, they cannot use Gore-Tex membranes. So we like to move to the other non-expandable or artificial membrane, but not those autologous fascia or muscles. It's very difficult to wrap those cysts by autologous fascia and muscles. So we usually use artificial membrane.
Okay. Mahmoud Nasser, I don't know from where. Thank you, Professor, for this informative presentation. For how long we can try conservative treatments, and when we offer surgery in a patient with only buttocks pain?
That's a good question. We do. So you have to be careful for the diagnosis first, and only buttock pain. It's not the case we do surgery, I guess. And in our series, if I doubt those symptoms are S2 pain, it's usually from the buttocks to the thigh, or only on the posterior surface of the thigh. It's a S2. I think it's S2 symptom. So only buttocks. So it may be, I showed one patient like a gluteal nerve trapping and neuropathy, or some other cases. So the only buttock pain, you have to be careful. It's maybe from the other the cause of the disease.
Thank you, sir. I don't see any other question or comment.
Elena, from Bulgaria, I think ask your email, Professor, to share her patients with you. If you write down the chat part, she can see. And now, Professor Kemal Yücesoy, you can. Okay.
Hi, Dr. Sugawara. It's really interesting technique, but I think it's usable for the small Tarlov cysts because I have a technique. It's published in Kobe Journal in 1999, and another technique in Journal of Spine Disorder for feeding off the bone by cement, and last journal, it's published in British Journal of Neurosurgery 2 years ago. It's more than 20 years follow-up result of my cases. I operated about 40 cases in 25 years. But the mean size over the 5 centimeters, 50 millimeters, it's too big. And yeah, it is not usable, your technique in my most cases. And after I removed the cyst fluid, and I dissected the membrane from the bone by a dissector. And during the this procedure, some venous bleeding, very high flow bleeding coming from the between the membrane and bone, and I inserted some. I insert some kind of surgical or sphingostone. And after that, I stirring the membrane in the midline and over the nerve tissue. You showed some this kind of the saving technique and like the and its recurrences show some recurrences, but I didn't see any recurrences in more than 20 years. Just stirring, and if the cyst enlarged the one side and made the big defects on the bone, and I inserted some acrylic, methyl methacrylate and cement in that side for the bone feeling, bone, the big side. I think, yeah, two different techniques. Your technique is really very good for the not too big cyst. Especially you made some osteoplastic laminotomy. It's not too easy in my cases because the bone is so thick and it's broken during the removing. And maybe we use the Gore-Tex during the surgery, especially for the make this syringomery carry cases with the in post for dural enlargement, and we use the same some stir. Maybe you can use the stir instead of the clip, and because of the good evaluation of MRI in the fellow period. What do you think?
Okay.
But I use your technique in the small cases.
Okay, I understand. I agree with you. We have you know, large cysts, several large cysts, more than 40 millimeters diameter, and we had the same problem. And in Japan, and then the patients are coming to our hospital have smaller cysts because in Japan, yeah, in Japan it's MRIs everywhere, and we have largest number of MRI in the world, I guess, and then everyone take MRI. So we have, that's why we have you know, the early stage cases, a lot of early stage cases, and maybe 200 or more patients came to the hospital, and only those surgeries indicated for just 30 patients or so. And firstly, a diagnosis, and if as you said, it's if it's very large, it's we have to have the special technique to, you know, prevent those CSF leak and other complications. And what do you do to prevent those CSF leak or nerve root injury for the larger cysts?
I saw only one case with CSF fistula, and she was very thin ladies, and it's not too easy to close the skin. And after the 2 or 3 months follow-up period, we make the revision surgery with the plastic surgeon, and they made the muscle transposition for the prevention of CSF fistula, but only one unique cases, because I shoot very thick, very tough, no waterproof, distribute waterproof suture. And I have very good pictures, and during the surgery and just after the surgery. I want to send you, maybe after you write your email, you can maybe imagine it very easily.
Okay. Okay. Thank
Yes.
you, Kemal. Nurullah,
Thank you.
Elena persist her
Okay.
question.
Elena from Bulgaria asks, during the operation, if there is complications like CSF leak, how do you repair it?
During operation, there is a completion. Repair it. Okay, so the we have to tell the same thing, like you know, if you are able to suture the dura, so we suture the dura and imbricate fashion, overlap those the cyst wall, overlap and suture the cyst wall. And the other thing is that we are doing it to use the fibrine glue and the absorbable membrane called nail veil. Do you know the nail veil? It's absorbable membrane. It helps to prevent the CSF leak from the cyst or from the skull or everywhere. So we do that, and the other thing what we are doing to prevent CSF leak is maybe to use this very small titanium clip. It's like vascular staple closure clips, the titanium clip, to not to make the hole, the suture hole, and just suture, just close the cyst. So we do yeah. I like to show those stuff, but I didn't have time to show. But we do those stuff. We use those stuff to prevent those CSF leak.
Okay.
Okay, sir, thank you. I don't see any other questions or comments. Dr. Suju, do you have any comments?
Thank you very much,
Last word.
Professor Sugawara.
Yes.
Weekend day, 45, at least 45 people attended your lecture, and it was very interesting, really. And thank you so much. And I want to thank everyone who joined us today to this conference. I hope to see you in the real life.
Okay. Yeah. Maybe I will see you at the meeting at the somewhere.
Yeah.
So thank you very much for the attention.
Thank you. Bye-bye.
Thank you, sir.
Bye.